The world has a significant problem in the fight against COVID-19. Anybody traveling today has the ability to contact, transport, and spread COVID-19 without even knowing. And by the time they do find out, it's usually too late. This also applies to the health officials tasked with protecting the community. All over the world, a third wave is already in motion, and the nations not in the right position will find the COVID-19 situation become more complex. The CNMI's success to date has been its ability to use technology to leverage its limited resources and work smarter, not harder. When COVID-19 first arrived in the Marianas, we were faced with fear of the unknown. No tracking systems. FEMA projected us to have 8,500 cases, the healthcare system being overrun, a remote location competing for supplies, the fear that an outbreak was too large to be contained. Under the direction and guidance of the health official Esther Muña and her CHCC team, support from the COVID-19 task force, and CNMI leadership, border protection is controlling the community transmission to virtually none. With the current protocols and systems in place, the CNMI at the moment has reached a critical milestone of over 100 days without a community case of COVID-19, with all new cases being tested, tracked, and quarantined safely at the border located in the designated CNMI government quarantine sites. So what's the secret? How have we been successful in preventing a CNMI-wide COVID-19 outbreak while also utilizing limited human resources, infrastructure, and supplies? 3 words: teamwork, communication, and data. Let me explain. We created an interconnected hybrid network of database systems that have the ability to track individuals and analyze data in real time with the collaboration and support of multiple teams that specialize in different parts of each system throughout the network. The hybrid network consists of the following dedicated systems: community surveillance, pre-arrival screening, SARA alert, CHCC all hazards database, contact tracing, CNMI COVID results, and data analytics. Now let's go more in depth. Let's begin with community surveillance. Due to our isolated location, close proximity of the disease transmission of Asia, the significant at-risk population due to health issues such as diabetes, a large outbreak would be difficult to manage, and we needed to create a system to monitor our local community ASAP. The community surveillance testing system gave our local population the convenience and safety to register to take PCR tests online, on-site, or through a call center. By providing individuals a multiple number of ways to access and register for PCR testing, it allowed us to hit a wide range of population demographics quickly and strategically in an organized manner. This gave the CNMI the ability to plan and prepare for the specific amount of scheduled registrant numbers in advance. By controlling registration to preset numbers on specific days each day of the week, we were able to allocate the right resources and record data accurately. We collected data such as contact information, employer information, what specific island, what specific village, medical history, and lab results, while also integrating and tying the data to their individual registrant ID. Now let's transition to the next system. The CNMI was one of the first locations in the world, as well as the first in the Pacific region, to implement and launch a pre-arrival screening system. The CNMI has also shown and proven it can effectively and safely open its borders with the system in place. Now that we are able to monitor the local community, we needed to create a system to process and control the flow of incoming travelers entering the CNMI. We understood that if we didn't control all our ports of entry, we left ourselves vulnerable to a massive outbreak. Addressing the need to control our border, the CNMI pre-arrival screening system was born, requiring all incoming travelers to register prior to their entry into the CNMI. This included airlines, sea traffic, meaning commercials and private ships, and the Department of Defense. The pre-arrival screening system is built with the ability to scale as needed and is highly customizable. Whether it's a flight of 5 passengers or 1,000, a military vessel or cruise liner, the CNMI is ready to track, analyze, and safely secure its borders. Travelers can register online, through the phone, or on arrival. With the registration, we verify travel information, essential worker requests, all before even entering into the CNMI. All travelers are provided a unique confirmation ID after submission of the registration. During the registration process, individuals are informed on all the current CNMI procedures with informational notices and requirements. This is to align expectations the CNMI is setting for all travelers. Individuals who request critical essential work must submit additional information which will need to be approved by the CNMI health official. Individuals will acknowledge the agreement form, fill in their specific traveler information, identify if passenger or crew, and notified locations traveled in the last 30 days. Provide either flight info or ship vessel information, identify as a resident or non-resident, and select final island destination. Provide location on Google Maps and describe specific location. Provide employment information and the ability to request essential status. Note, essential requests will need to provide more details and acknowledge agreement. Fill out the SARA Alert registration information and acknowledge agreement. Will you or have you been tested for COVID-19? If it's in less than 72 hours, please provide the testing platform and specific details. If you're a prior positive case, please provide the testing platform and specific details. From there, you'll also fill out the medical information and acknowledge agreement towards the very end. This unique confirmation ID can be used to track individuals from their arrival, connecting their lab data, accessing test results, quarantine management, SARA Alert monitoring system, and contact tracing, while also maintaining patient data confidentiality. With the system now in place, health officials and the state are able to track travelers prior to entering the CNMI and follow them through the entire surveillance process from arrival at the airport or seaport to leaving the quarantine facility on their last day. Remember that confirmation ID? Health officials in the state are able to check in, transfer, record specific information, analyze, and check out all travelers entering and leaving a quarantine facility through their unique confirmation ID. Do they have food allergies? Are they ADA? You can record that as well. Have limited contact tracers? No problem. With the system, contact tracers can readily access a summary of registrant information, including home addresses, contact information, airline seat assignments, and track and analyze any testing, pre-arrival, post-arrival, and quarantine information. Now, let's introduce the next system. The CNMI currently utilizes the SARA Alert system for secure monitoring and reporting of symptoms related to COVID-19. Once individuals are enrolled into the system, they are monitored for a period of 14 days. The system contacts an individual through phone call, text message, or email with a set of questions that involve their current health status. The CNMI SARA Alert team are responsible for following up on individuals who report symptomatic or miss a report for the day. Once a report is confirmed as a public health concern, coordination for care is conducted. The enrollment of incoming passengers into the SARA Alert system works efficiently through a partnership between the CNMI COVID Task Force, CNMI SARA Alert Team, the Commonwealth Healthcare Corporation, and Turnkey Solutions. The system features an analytics dashboard, which is exportable as a PNG file. The following reporting elements are available: monitoring status by risk level amongst those currently under active monitoring, monitoring flow over time, newly enrollments, closed cases, transfers, age, sex, risk. For this next system, I would like to introduce Belle Busby, the main developer for the CHCC All Hazards database.
In early 2020, coronavirus has infected many people worldwide and it reached the island of Saipan. But with the collaboration of CHCC team and the Governor's Task Force, community safety is in place and it continues to thrive. but with the safety of the community comes the continuous flow of data. No, not that data. Patient's data. Patient data is being gathered in different formats, some in papers, others in digital form. Yes, that's what I mean. Spreadsheets. Lots and lots of spreadsheets. Because of COVID-19, All Hazard Database application was born. All Hazard enables us to enter data through different area of interest, and it's accessible through any browser inside CHCC network. Data from arrivals are regularly being uploaded to All Hazard. Patient record can be searched by entering either the confirmation ID that TK Solutions provided or through patient's last name. Results are being entered by laboratory personnel. After the laboratory personnel enter the results, data is extracted to send to TK Solutions platform. All Hazard has customized report extraction that can be exported to Excel spreadsheets. We are now in the process of implementing workload management system for our communicable disease investigation and inspection team. Thank you.
On this next system, I'm going to hand it off to Victoria to talk about contact tracing.
Geographic Information Systems, or GIS, was utilized as a tool for data visualization to assist with contact tracing, data sharing, and decision-making efforts. At the beginning of our response, we utilized GIS to visualize which communities individuals lived in who availed of our community-based testing initiative. Through this effort, we were able to see which communities to target to encourage testing and could figure out if there were barriers in place limiting individuals from getting tested. Additionally, we created bivariate maps that overlaid cases with testing data to identify communities with high cases and low testing rates, and vice versa. GIS was also used to assist with contact tracing efforts. At a baseline level, all cases were mapped to visualize the locations they went to, as well as contacts at each location. These maps were compiled and integrated with a time component to identify locations of interest. An internal contact tracing dashboard was then developed that connected a map, time chart, and link charts together to conduct analyses based off of various locations, dates, and cases or contacts of interest. In an effort to increase data transparency with the public, we then created the COVID-19 data dashboard through the assistance of the CDC and ESRI. The dashboard presents data pertaining to COVID-19 diagnoses, testing information, demographics, and trends. It presents information via maps as well as through raw numbers and graphs or charts.
Great job, Victoria. Keep up the good work. Now let's transition to CNMI COVID results. CNMI COVID results was created to leverage limited resources and have the ability to have test results online. That way people could get their results in real time. The system is also being used to link testing data to traveler confirmation IDs in real time and provides access to test results through an online platform or call center. This helps to limit the amount of human resources and provides convenience for the travelers to get their results.
Data. As shown earlier, having information is critical as no one knew how many community members were COVID-19 positive and were potentially spreading the virus around. So with the goal of finding out, community-based testing was established to determine the number of positives and to contact trace and identify where potential clusters were, if any. At the same time, controlling our borders via the establishment of the incoming traveler testing and quarantine requirements was necessary. With the systems being up for some time, the CNMI has gathered over 700,000 field values across the CBT and HDF databases. CBT data. Since the launch of the CBT web platform back in May 18, 2020, the CNMI has captured a significant amount of data, and being able to interpret this data is critical to making better decisions. As shown in Victoria's presentation, the input of data into the GIS does wonders in transforming raw information into meaningful and comprehensive information. As of December 8, 2020, the CBT database has captured over 7,000 registrations containing over 260,000 field values. The total specimens tested on saipan, tinian, and rota is 7,136. Below are some examples of what can be done with CBT data. We can see here in the testing by age range pie chart that the 46 and older age range makes up of 36% of the testing, and minors make up only 8%. And here on the CBT ethnicity pie chart, most of those who were tested were of Filipino and Chamorro ethnicity at 36% and 31% respectively. HDF data. Since the launch of the HDF web platform back in August 24, 2020, the CNMI has captured over 5,000 registrations containing over 430,000 field values as of December 8, 2020. A total of 8,353 specimens have been collected on port of entries and quarantine facilities from day 1 and day 5 testing. Below are some examples of what can be done with HDF data. As we can see from these charts, on the left side, final destination, we noted that 92% of incoming travelers have their final destination as Saipan, while Rota and Tinian are both at 4%. In the sex or gender pie chart, about 57% of those incoming travelers are male, while the remaining 43% are female. On the residency pie chart, we noted that the residency of incoming travelers is a 4-to-1 ratio of residents to non-residents. Now, as you're aware, there is great flexibility in utilizing the data captured from building linear time graphs to conducting regression analysis and many more. You do not have to limit yourself to pie charts like I did, as this was for simple illustrative purposes. What if scenario? The cumulative confirmed COVID-19 case positive percentage for the US is estimated at 4.48% according to CDC and US Census data as of December 8, 2020. If applied to the CNMI's estimated population of 53,889 individuals according to its last US Census, the CNMI is estimated to have had around 2,416 cases by December 8, 2020. Of these cases, the ICU hospitalization rate of confirmed COVID-19 positives is around 5.86% based on the latest CDC COVID-19 hospitalization. As a result, the CNMI would have had around 142 patients that required ICU hospitalization. The average cost of ICU hospitalization in the CNMI is around $4,000 per day, and the average length of time a COVID-19 positive patient remains in ICU is between 11 days for survivors and 14 days for mortality patients. Consequently, the estimated healthcare costs attributed to caring for COVID-19 positives hospitalization would have costed the CNMI government an estimated $6.8 million with 48 mortalities if little was done to control this outbreak. How do we compare? Here we have a simple estimated versus actual COVID-19 data table that compares confirmed cases, hospitalizations, and deaths as of December 8, 2020. As you can see, the CNMI system works, with the actual confirmed cases being only 5% at 111 cases of what the CNMI is estimated to have, which again is 2,416. And the hospitalization is only 3% at 4 of the estimated 142. And lastly, death only 4% at 2 of the estimated 48.
Awesome job, Charlie. We appreciate your work. Now that you have seen the key systems that are making the CNMI successful, we hope that you too can learn to adopt a systematic approach to attack COVID-19 as well. Thank you for listening. and we hope you learned something new today.